Bismillahirrahmanirrahim. Assalamu alaikum and a very good morning to everyone. I congratulate Dr. Nazli for making this dream come true despite all odds. Alhamdulillah, proud to represent Farooq Group of Hospitals and Medical Colleges, which is one of the largest group in the country. And I am working as Medical Director, Australian Concept Infertility Medical Center in Farooq Hospital, DHA. I'm going to talk about the rationale, about the objective of my study, which is to show how the hysteroscopy is a gold standard for evaluating and treating intrauterine pathologies in patients presenting with subfertility. As my colleagues have talked about the role of fallopian tubes, tubal patency and tubal health in subfertility, so all of us know about the role of endometrium and the uterine cavity. Because without clearing the endometrial cavity, we cannot do any plantation. So definitely embryo will not implant unless we clear the uterine cavity of all the polyps and everything else. This was a study which was done from January 2024 to September 2025. It was done in Farooq Hospitals, Westwood and DHA. And IRB approval was obtained from AMDC, Gynae 9824. The inclusion criteria was all the subfertile women presenting, undergoing diagnostic or therapeutic hysteroscopy during this period. Data was collected using a performer, and after taking the informed consent, the procedures was done. Total number of participants was 224. Age ranges between 20 to 45 years, and the mean age was 32.5 years. So these are the hysteroscopic findings. You can see that almost 52% patients, they had normal hysteroscopic findings. And regarding those who had pathologies, the most common pathology was endometrial polyp. And after that, we had in this graph you can see, endometrial polyps were seen in 22.7%, submucosal fibroids in 4.4%, embedded IUCDs in 3.5%, simple hyperplasia in 3.1%, atrophic endometrium was present in 0.4%, retained or calcified RPOCs in 3.1%, Asherman syndrome intrauterine adhesions 1.3%, and surprisingly, congenital uterine anomalies were very common following endometrial polyps, that is 7.5% in my study, maybe because I got referral from of these patients from different my colleagues. Then bone fragments, retained bony fragments was in 1.3%, and osseous metaplasia was 0.4%, which is a very rare finding, and very few cases in literature has been present. So in these videos, you can see the endometrial polyps. I saw different types of polyps, sessile, pedunculated, multiple. So here you can see the two polyps. Then this was another patient. On the left side, you can see a polyp which was hanging out of the vaginal introitus, but its base was attached to the uterine fundus, which was removed carefully with the help of scissors in this diagram. And in the other video, you can see the polyp you saw previously. It was all the polyps, they were removed with the help of scissors. Some were removed with the help of biopsy forceps. It's important to remove the base from its endometrial attachment so that we can prevent the regrowth of the polyps frequently. So in this video, you can see the different polyps, multiple polyps on hysteroscopy, and these polyps, they were removed with the help of scissors. Although one polyp was seen on ultrasound, but when we did the hysteroscopy, we saw multiple polyps, and all of them were beautifully removed by cutting at the basis and removing the polyps with the help of sponge holding of this hysteroscopic forceps. So it's important to, when a little bit of base is attached, you should take hold of that base with the help of sponge holding forceps so that it should not move inside the endometrial cavity, and here you can see the whole of it was held with the forceps, and then it was removed as a whole. Now, similarly, in this picture, you can see multiple polyps on the right side. This was the maximum number of polyps seen in any patient. Then transcervical resection of myomas. Myomas was the second pathology after polyps. Here you can see transcervical resection in a patient who had 5 into 4 centimeter fibroid. It was type 0 fibroid occupying whole of the endometrial cavity. And in the other video, you can see, although it was very vascular, but I did monopolar this resectoscope, and very beautifully, all the blood vessels, they were coagulated. And luckily, her name was Sadia, and she conceived after this procedure. This is another diagram, another video. Here, I want to show you that I removed large fibroids. This was approximately 6 into 5 centimeter. It's important you should cut the longitudinal slices of the fibroid with the help of resectoscope. Later on, if you dilate the cervix, you can remove them with the help of a sponge holding forceps or with the help of long artery forceps. So there is no need to cut them into small pieces to reduce the time and to reduce this, if you have monopolar resectoscope, to reduce this electrolyte imbalance with the glycine. Another picture here. Here you can see ये video नहीं on हो रही. So here you can also see that longitudinal slices were cut and it was removed with the help of long artery forceps. Another beautiful picture. On ultrasound you can see this image. Here you can see on ultrasound it was clear that it's some mass, not clear whether it was a fibroid or it was a polyp. Again, it was removed with the long artery forceps. Then I also had the experience of removing the fibroid with the help of MyoSure. The only good thing about MyoSure was that it was less time consuming. This patient had one polyp and one submucosal fibroid. So you can see within few seconds, just 40 seconds, the whole of the fibroid was removed using this MyoSure, because it did mechanical morcellation and no energy is used, and later on less incidence of intrauterine adhesions or damage to the endometrial cavity. This is a very interesting thing. I told you that 2 patients had bony fragments. These 2 patients give history of missed miscarriages or incomplete miscarriages treated with a dye or some LHVs. And here you can see in this video, this is on the left side, you can see the bony fragments visible in the endometrial cavity. And then the bony fragments were held with the help of forceps. And later on, the histopathology biopsy of the bony fragments confirmed that they were bone. In this, another type of bone was seen in this patient. She had amenorrhea for the last 1 year after she had intervention with the dye for an incomplete miscarriage. You can see different types of bones in here also, and they looked like some, I think, scapula or something like that, and they were flat bones rather than the longitudinal bone you saw in the previous diagram, in the previous video. This also this was the case of osseous metaplasia. I call it osseous metaplasia because this patient did not give any history of pregnancy loss. So when I washed the fragments, the bony fragments, piche wali video. So different types of bone-like structures of almost the same shape that were removed. Unfortunately, that video is not playing because in that video you can see, in the middle picture, you can see this type of bone. They were deeply embedded in the endometrium. Initially, when I put in the stereoscope, I did not see anything, but later on, when I went deep, it was clear. So this was another patient with primary subfertility. What was on ultrasound, there were some echogenic features, but when I saw it was a Lippes loop, and patient was not aware that Lippes loop was inserted in her, and who inserted her. She had some treatment from local LHVs and dyes. RPOCs after DNC, this patient had multiple miscarriages, previous 4 miscarriages, and she had DNC in UK. She came to me for diagnostic hysteroscopy, and you can see this retained POCs, and they were removed with the help of the forceps. So whenever you do recurrent DNC or recurrent removal of RPOCs, please use hysteroscope, because sometimes they are deeply embedded and they cannot be removed by simple section evacuation or by simple curettage. Similarly, this was another patient. It looked like a septum, but it was not a septum. It was actually retained POCs. And when I did this, I cut the adhesions, and later on, retained POCs were removed in this patient. Septum resection. All of us, we do septum resection. We can do it with scissors, with the Collins knife. But in my experience, here a picture, you can see double camera system is required. When you remove the septum, the uterus, the uterine fundus bulges out. And please only do septal resection when the fundus is flat. Septum with bipolar was also done. Bipolar is good option when you do not have bipolar resectoscope. This was a bipolar. This last slide, I want to show this because it was a very interesting picture. I don't know why the video is not working, but I just want to show you because this was on the left side. You can this was a patient who had severe dysmenorrhea. The vaginal length was only 2 centimeter. On the left side, you can see a transverse septum with only a small hole on the left side. So when I put in the hysteroscope, when I went inside, there was another anomaly. I went inside this small hole in the vaginal septum, and what I saw was there was a longitudinal vaginal septum, partial septum also present in the uterine cavity, and in the second sitting, that septum was removed with the help of scissors. And now this patient has no more dyspareunia. So conclusion is that the hysteroscopy provides superior sensitivity and specificity as compared to transvaginal scan and other modalities. Thank you so much.